Welcome, everyone. My name is John Holman. I'm Vice President of Medical Affairs at Transplant Genomics. I appreciate you sharing some time with us today. Our symposium is entitled The Management of Kidney Transplant Patients Using TruGraf and TRAC for Surveillance. Our first speaker today is Dr. John Friedewald. John is the Medical Director of Kidney and Pancreas Transplantation at the Northwestern Comprehensive Transplant Center in Chicago, and he will be speaking today on the overview of TruGraf.
Thank you very much, Dr. Holman. It's a pleasure to be with everyone today, coming to you from Chicago, wherever you are in the world. Thank you for joining us. I'm going to provide an overview of the TruGraf test. I have the following disclosures. I'm a clinical advisor for Transplant Genomics, and I have grant funding from Eurofins Viracor. So what is TruGraf? TruGraf is a test that was designed with a very specific purpose. Some tests are born looking for a disease, I like to say, and others, we start with a specific disease and develop a test, and that's what we did with the TruGraf test. So TruGraf is a blood gene expression profile test developed very specifically to detect the absence or presence of subclinical rejection in kidney transplant recipients who are otherwise stable. What is subclinical rejection? Very important to define the clinical phenotype. We define subclinical rejection by three things. Number one, normal renal function, and we chose a cutoff of 2.3 milligrams per deciliter below that as normal kidney function. And there is nothing magic about that number. We chose it because we wanted to be inclusive of patients who maybe had a higher level of serum creatinine, but otherwise a stable and healthy graft, perhaps due to donor disease. So we chose that number. Number two, stable renal function, defined by a change less than 20% from prior values. And number three, rejection on a surveillance biopsy done just to check the kidney for subclinical rejection. So those things define subclinical acute rejection. And we did a study to determine this. It was the CTOT-8 clinical trial. And in that study, we did two things. We developed the clinical validity of a novel blood-based biomarker for subclinical rejection following kidney transplant. We also defined the disease itself. So in a large multi-center trial here in the US, we defined the frequency and the importance of subclinical rejection. Critically, that even borderline rejection are meaningful in terms of clinical endpoints. Now, that important finding was found in our clinical trial, but it was also echoed in several other publications in the same year. So the group from Pittsburgh has published this, and actually a more recent paper looking at, again, early graft inflammation on protocol biopsies leading to poor clinical outcomes. And I'll show you what those are. Number two, a group from the University of Alabama, Birmingham, in a pediatric population looked at early rejection, subclinical rejection. And this group I'll show you later actually showed that treating subclinical rejection improved outcomes. Number three, the very large and well-designed GOCAR trial, similar to the CTOT-8 trial, did surveillance biopsies in a large number of patients in the first 2 years and found, again, that subclinical rejection associated with worse clinical outcomes. And finally, the group from Australia published a similar paper, again, showing that low-grade inflammation in the kidney leads to bad outcomes. And so detecting this inflammation early and treating it is a key goal to improving long-term graft survival. So how often does subclinical rejection occur? We found in the CTOT-8 trial, and this was very similar to the GOCAR trial, where surveillance biopsies were done at 3, 12, and 24 months post-transplant. And we found the point prevalence to be fairly similar at all those time points. So 20% of patients biopsied at 3 months had subclinical rejection, 25% at 1 year, and 25% at the 2-year mark. Overall, if you look at a subject level, because patients could have more than one biopsy showing subclinical rejection, 35% of patients in the study had at least one biopsy with subclinical rejection. And when we broke down the type of rejection, most were cellular rejection, T-cell mediated, and most were borderline. 70% were borderline rejection. 30% were either 1A or greater or antibody-mediated rejection, or some combination of those. So I mentioned it, but what are the consequences of subclinical rejection? Why do we care? This shows why. So we know from both the CTOT-8 and the GOCAR trial, as well as the other trials I mentioned, that there's a higher risk of going on to develop clinical acute rejection after an episode of subclinical rejection. Patients who have subclinical rejection are more likely to form de novo DSA, statistically significant. They're more likely to lose the graft at 5 years, and that's shown here in the GOCAR trial, where patients at the 3-month biopsy who had no acute cellular rejection versus those that did, and this is subclinical, though those that had rejection had a worse graft survival at 5 years. They're more likely to develop fibrosis in the graft, grade 2 IFTA or greater, and that was shown in the CTOT-8 trial as well as the other trials, and a more rapid loss of GFR. And we've now followed our CTOT-8 patients out to 5 years, and we see a steeper drop in GFR, decline in GFR in patients that had early subclinical rejection. So all of these things together, of course, are early harbingers of graft loss and worse graft outcome long-term. And so we really need to focus on the early events going on in the graft and prevent those from happening. So now we know also that treating subclinical rejection improves outcomes, both subclinical antibody-mediated and T-cell mediated rejection. And this is one paper from the group at University of Wisconsin showing treating subclinical antibody-mediated rejection improved outcomes. In this study, they were looking at just donor-specific antibody development and doing biopsies based on that biomarker. And what they again found is if you treat early, the outcomes for those early treated patients are very similar to those that did not have any rejection at all. And I mentioned the group from University of Alabama, Birmingham, and pediatric patients treated pediatric patients with T-cell mediated rejection, primarily subclinical. And again, the treated subclinical rejection did better than those untreated. And so there's evidence both now for cellular and antibody mediated rejection, subclinical, that treating improves outcomes. So let's take a step back and talk about how do we discover a gene expression test? What is that? The way we did this in the CTOT-8 trial was we took a number of patients who had biopsies, 530 biopsies, all paired with blood samples. So we knew what the clinical phenotype was based on the biopsy. Then we looked at the blood samples of those patients. We had 400 patients who had a normal biopsy. We call that transplant excellent. And that's, again, stable renal function, normal renal function with a negative biopsy. And we took those that had subclinical rejection as previously defined. And then we looked at the differences in gene expression in those two groups by looking at an Affymetrix gene array. This is a whole exome array. We then filtered those genes by a bioinformatics process, and we used a random forest model that asked the question, what set of genes best tells these two groups apart based on their differential expression at that time point in the blood? It turns out the TruGraf gene expression profile consists of 120 genes that are either up or down regulated and specifically chosen to distinguish stable biopsies from those with subclinical rejection. So again, this is a very specific test for this disease, and that's important. The TruGraf test has been validated in external cohorts. This is a publication from Chris Marsh and colleagues looking at 7 US transplant centers who use the TruGraf test in the setting of patients that are stable and being biopsied. The accuracy of the result of a TX or a normal result was very accurate across the different centers. And you can see the performance was the same as in the CTOT-8 trial, a high negative predictive value about 89% and a positive predictive value of 48%. So again, the TruGraf test is very good at ruling out subclinical rejection and knowing that a patient doesn't need a surveillance biopsy, that you can do without it and know they're stable. I'm going to move on to a few examples that illustrate how the TruGraf test can be used. And in these slides, I also have data from a cell-free DNA assay called the TRAC assay. And the way this works is this is a single patient. This patient was followed for 2 years in the CTOT-8 trial. Patient had serial biopsies shown here along the bottom and TruGraf testing here. And you can see at 3 months and on the other time points. Now, the TruGraf testing in the study was not available at the time of the clinical trial. So the patient was treated based on biopsies alone. We then went back after we discovered the TruGraf gene expression assay and looked at what the TruGraf assay would have shown at those time points. And you can see this patient, the serum creatinine is shown here in orange. So a fairly normal, good, stable creatinine out to 3 months. But at 3 months, the patient had a non-TX TruGraf result, which means an abnormal result. The biopsy just showed interstitial fibrosis and tubular atrophy grade 1, but no rejection based on the biopsy read. Now, at that point, following that, the patient's creatinine started to creep up. At this point, at 6 months, the patient had a 4-cause biopsy. And again, TruGraf is not indicated currently in the setting of graft dysfunction, so a TruGraf test was not done at the time. The patient went on to have a BAMF2A acute cellular rejection. Interestingly, they also had thrombotic microangiopathy. And when we look at the cell-free DNA assay, which is positive above 0.7, you can see the cell-free DNA was going crazy. What we know about cell-free DNA is it's very sensitive to, very specific for vascular injury. And obviously a thrombotic microangiopathy, there's a lot of endothelial injury releasing a lot of cell-free DNA into the circulation. And so the cell-free DNA was off the charts. Again, this was obtained retrospectively. We didn't know it at the time. The patient was treated with steroids. And because of the thrombotic microangiopathy, they were also treated with plasmapheresis and IVIG. They were given antithymocyte globulin, and their tacrolimus was discontinued, thinking that was contributing to thrombotic microangiopathy. The patient improved, the cell-free DNA improved, And the TruGraf test went back to TX after treatment of rejection here. But again, a month later, a follow-up TruGraf test, and I'll show you the value of follow-up testing after a rejection episode. The TruGraf is back to being non-TX. The creatinine went back up again. Another biopsy was done showing borderline acute cellular rejection and persistent thrombotic microangiopathy. Interestingly, at this time, the cell-free DNA was down now at a very low level. The patient was treated with anti-C5 therapy. Serum creatinine stabilized and continued to improve over the time. At the 1-year mark, the patient had another non-TX TruGraf result, and again, just showed interstitial fibrosis and tubular atrophy. They then went on to have 2 more TX results later on, again with the stabilized serum creatinine. But at the 2-year mark, they had a non-TX TruGraf result, again a biopsy showing borderline acute cellular rejection, treated with an increase in maintenance immune suppression. So you can see how the TruGraf testing can mirror what's going on in the biopsies and eventually replace what we need for biopsies in stable patients. This is a patient who had subclinical acute cellular rejection, which eventually evolved into antibody-mediated rejection. And I wanted to show this case because I think when we think about how this happens in an individual kidney graft, we have an early cellular response, which then leads to a memory response and antibodies. And this is a great example of that. So this patient, again, had an early course that was very good. And if you, again, look at just the patient's serum creatinine, it was normal throughout the 2-year trial. So if you just were following serum creatinine, you might see that this person was doing totally fine. At 3 months, they had a normal biopsy and a TX TruGraf result, so potentially they could have been spared that biopsy. By 1 year, though, the TruGraf test is non-TX abnormal, and we find borderline acute cellular rejection. Now, at the time, it was clinician preference in the trial. It was not an interventional trial. The clinician chose not to treat those borderline infiltrates. But what we know is those borderline infiltrates, when they hang around for a while, can lead to ongoing immune response. And sure enough, by 15 months, the patient goes on to have, again, a non-TX TruGraf result, a biopsy done because they developed some proteinuria, and they're found to have borderline acute cellular rejection, which is persistent. And now they develop the antibody-mediated rejection and a new de novo donor-specific antibody. At that time, also, the cell-free DNA is positive at a level of 1. The patient's treated with steroid pulse, IVIG, and rituximab. You can see the cell-free DNA, which was tracked, went up to 8 and up to 10 eventually. Now, some time goes by. At the 2-year mark, they have another surveillance biopsy with, again, stable serum creatinine. The TruGraf is still not TX abnormal. The biopsy still shows AMR. Cell-free DNA is high, and they're treated again with another round of steroids, plasmapheresis, and IVIG. So again, showing a lot can be going on with stable serum creatinine that you'd be missing if you weren't looking deeper, either with biopsies or with biomarkers. And the message here is that biomarkers can often spare patients biopsies when they don't need them, or indicate when they're needed and to diagnose disease early. Here's a patient that was a highly sensitized patient who underwent pre-transplant desensitization for an HLA positive cross-match. I just want to illustrate this because this shows how, again, gene expression profiling like TruGraf can work in conjunction with cell-free DNA. So again, this patient early on, again, had a perfectly good course in terms of their kidney function, very stable and normal serum creatinine throughout the 2 years. But again, if you dig deeper, you see that cell-free DNA, which is normal at 3 months, is up by 6 months above normal. And then you have a spike here by 9 months, but because the protocol was stable kidney function, they only had a biopsy at 12 months. At that time, the TruGraf test is abnormal, not TX. The biopsy shows subclinical antibody-mediated rejection. Patient is treated with rituximab and IVIG in the face of stable renal function. Cell-free DNA, which again was found retrospectively, was still high this whole time. They had a follow-up biopsy in 3 months per the clinical protocol. Again, the TruGraf is still abnormal, not TX. Biopsy still shows subclinical AMR. They're treated with additional rounds of intravenous immunoglobulin. Cell-free DNA now comes down. And by the 24-month time period, they got a normal biopsy with a TX TruGraf result. I think this is a great illustration of how both biomarkers can help track the course of a patient over time and inform interventions. Okay, I mentioned follow-up for treatment. So in the CTOT-8 trial, all patients that had subclinical rejection of either type had a follow-up biopsy at 8 weeks, and that's shown here. So here, all the patients at biopsy time point had subclinical rejection, either cellular or antibody-mediated. They all had blood sampling every 2 weeks at these intense monitoring visits, and then at 8 weeks, they had a biopsy. And what was surprising is after 8 weeks, only half the patients had resolved their rejection based on histology. More than half, 52%, still had ongoing rejection at the time, even though, again, these patients all have stable renal function. What we also found was interesting is if you look at the biomarker, which is the positive negative line is here, the groups that resolved their rejection, shown here in red, versus the group that had unresolved histologic rejection in black, a couple interesting things emerged. Number one is at the baseline biopsy, about half the patients who had resolved their rejection had a negative biomarker to begin with. And again, the biomarkers were done retrospectively. But almost all the patients that didn't have resolution of rejection had a positive biomarker at baseline. By the time treatment was done, again, most of the people that did not resolve still had a positive biomarker, where most of the patients that had resolution had a negative biomarker. So what this tells us is we can then monitor patients after treatment. I showed one example of that in the previous clinical example, how the biomarker can tell you whether a patient has had resolution or not of rejection after treatment. So how do we use this test, a monitoring algorithm? You have a lot of patients, and I think of this like a shepherd. You're shepherding your flock, and there are a lot of them. What do you do? How do you monitor them? How do you know what to do? So the TruGraf can help you decide what to do. So you do a TruGraf test on your stable patients, and many of them, about 2/3 to 3/4, are going to have a negative test. Those patients can simply be reassured and monitored without needing an invasive protocol biopsy. And again, as LPP, not only do they spare a biopsy, but they also get that reassurance, which for patients is really important to tell them you're doing okay. Then you can take the smaller group of patients, which are more manageable, and say, you've got an abnormal test result. We probably should do further evaluation, whether that's a biopsy or other testing or treatment, such as adjustment of immunosuppression, baseline immunosuppression. But at least you can focus your efforts on patients who need more of your attention and reassures those that are doing well. So in summary, subclinical rejection is common. About 1/3 of the patients have it in the first 2 years of their transplant. Was previously only detected by surveillance biopsies and is associated with inferior graft outcomes. Further episodes of rejection, development of de novo donor-specific antibodies, lower GFR, fibrosis, and graft loss. Monitoring with the TruGraf test can provide confidence that your patient's not having subclinical rejection and alleviate the need for invasive surveillance biopsies. And early detection of subclinical rejection and treatment improves outcomes. Thank you very much for your attention. I'd be happy to take any questions.
So Dr. Friedewald, that was a very excellent talk, as always. I noticed one of your cases that you identified had a non-TX TruGraf assay in the face of a stable serum creatinine, but they had IFTA on the biopsy. Could you comment on the picking up of IFTA with the non-TX TruGraf assay?
Yeah, Dr. Holman, thanks for the question. And, I think in that case, this was an early time point. So just addressing the IFTA on the biopsy, my guess is that's probably donor-related disease that came along with the kidney. It was a deceased donor kidney transplant, so that's probably the most likely explanation there. The non-TX abnormal TruGraf result, it's unclear. So one of the analyses we're doing currently is we're looking at serial samples prior to rejection to see how early a TruGraf test would turn abnormal, not TX, before a rejection episode. So those data are forthcoming. Stay tuned. At that point, though, it could be considered a false positive. But again, we don't know if that was a harbinger of things to come because that patient did go on to develop rejection later on.
I think this is a very exciting technology, and the application of precision medicine to kids, I think, would be very important. They have issues that we're all familiar with non-adherence and actually the potential for under-immunosuppression just as they grow up and their metabolism changes. What do you think would be the application of this technology to children?
Yeah, thanks. That's another great question. And, I'll say again that we've been for so long working with non-specific markers of injury to the kidney, which are very insensitive to rejection. And so to have a test that is specifically designed to detect that phenotype, I think is a real step forward. It couldn't be more so in children because, obviously, biopsying a pediatric patient is riskier than an adult patient. They often need anesthesia for the procedure, whereas we typically in our practice just use some local anesthetic for a biopsy. And so I think, being able to, number one, more safely monitor the graft of a young patient, but number two, of course, pediatric patients have much more runway with their transplants, and detecting early immune activation and injury is all the more important for them to make their graft survival even longer. And again, where we started was long-term graft outcomes are not good. Why? Oh, it's because of early graft inflammation and injury. And so we're really focusing way upstream from the problems that happen later on to try to prevent them from happening. And this is one way to do that. So we hope there'll be a great application for pediatric patients.
Thank you, Dr. Friedewald, for your presentation. We really appreciate you spending their time with us. Thank you.